Good afternoon. My second talk is immunomodulatory treatment in recurrent miscarriage and multiple implantation failure. So there are multiple targets we can think about. The whole goal of the treatment is having a good success rate of the delivery. So the objective should meet this. So potential treatment should provide a success rate higher than that of supportive therapy. And treatment should be safe for both mother and the baby. And the treatment should be cost effective. So these are the treatments so far presented for the women with the recurrent pregnancy losses. Some of them are actually tried for the multiple implantation failure too. So steroids, heparin, aspirin, IVIG, which is intravenous immunoglobulin G, and LIT using a paternal and donor. And then some of the investigational drugs or the lesser studies are including cytotoxic medications such as cyclosporine or hydrochloroquine, or the cytokine modulators such as anti-TNF or the TNF receptor blockers or GCSF, and the cellular immune modulators like intralipids been presented before. So inflammation and the coagulations are kinetically coupled events. I talked about this morning. And coagulopathy induces the inflammatory immune response. And we talked about antiphospholipid antibody syndrome has a strong inflammatory component. So modulation of inflammation is very important for this population. And recent heparin trials are all kind of reported to be the failure case, and why they are failing. That is the question. And then when you have a heparin treatment, there are some side effects we have to deal with. And then when we have a heparin treatment, still we see the second, third trimester complication in APS patient population, which raised the question about why we have to think about the immune modulation. So this is the recent trial of low molecular weight heparin called a LIFE study. It was a multi-center randomized placebo control, and it was aspirin combined with a low molecular weight heparin and the aspirin alone. And it was open label, and the heparin was started 6 weeks the post-conception. And they have to know at least 2 miscarriages of unknown etiology, and then cardiolipin, lupus anticoagulant, Leiden factor 5, prothrombin gene, etc., were screened and then eliminated. And then they give the folic acid starting before the conception and continuing until 10 weeks of gestation. So to me, these are the ones who really need the heparin, but then they eliminate it and wanted to see somebody who doesn't have any thrombophilic effects, how much the heparin can help. So when you see the outcome, they didn't see any difference in here. Placebo, aspirin plus nadropirin, and aspirin only, there is no difference. Based on the intention to treat population, this is the actual, patient population. They received the treatment and finished the treatment protocol. Again, there was no effect of the heparin. So when you read this thing, you really need to be carefully read about their design. This trial is for so-called the unknown etiology recurrent aborters. It's not for the coagulopathy patients. And heparin was reported to, prevent the antiphospholipid antibody-induced trophoblast inflammation and also inhibit antiphospholipid trigger trophoblast cell death. So heparin is not only the anticoagulant, it has some anti-inflammatory component, and it suppresses the natural killer cell cytotoxicity and prevent the leukocyte adhesion and block the interferon gamma signaling and inhibit the complement activation and promotion of the growth factor. So heparin does a lot more than a anticoagulant. However, both unfractionated heparin or the regular heparin are unable to reverse the effect of anti-beta to GP1 monoclonal antibody on trophoblast IL-6 production and the migration. And this patient who's going through the heparin treatment has even higher incidence of preeclampsia. So it really we have to think about the heparin treatment more carefully. So we've been using the prednisone, and since prednisone is so common, you really don't have that much chance to look at the prednisone effect. The prednisone does suppress the TNF-alpha, IL-6, and IL-8 and MCP-1 production. And these are the actual human study. They got the LPS small dose, and then they were treated with the prednisone 3 milligram, 10 milligram, and 30 milligrams. So these are very therapeutic ranges. As you can see here, this is a 3 milligram. 10 and 30 does almost similar in TNF-alpha, IL-6, and IL-8, and MCP-1. So prednisone 10 to 30 milligram works pretty well. And then also prednisone activate the TATC, and then there's no much changes in prothrombin fragment. And then soluble factor production was slightly increased. So prednisone really did not inhibit the LPS-induced anticoagulation activation. So prednisone suppresses anti-inflammatory, but it does not inhibit the coagulation activation or the activation of fibrinolysis. So prednisone is a drug only working on the inflammation, not that much on the fibrinolysis or the anticoagulation. So when they get the LPS, and actually prednisone treatment induced the PEP-C, and then also induced the tissue plasminogen activator, not that much changes in PAI-1. So you can see the prednisone effect with this type of human study. It controls the inflammation well, but not really controlling the coagulation or the fibrinolysis. So prednisone and the dexamethasones are often utilized by the physicians when they go through the recurrent pregnancy loss patient, or dexamethasone is the one the IVF physicians are using quite a bit. And prednisone and dexamethasone has dose-dependently inhibit pro-inflammatory cytokine release and inhibit endothelial cell activation, neutrophil activation, and acute phase response. But it moderately enhances, thus does not inhibit the activation of coagulation and fibrinolysis. So it has some limitation in here. And when dexamethasone was administered to the health volunteer, actually the level of factor 7, 13, 7, 8, and 11, and fibrinogen, von Willebrand factor, and P-selectins are all increased. So it induces the activation of coagulopathy. So there are trials done like a prednisone and low-dose aspirin, and this was a double-blind trial in patients with a 2 or more unexplained abortion, and they have a low titer of autoantibodies. And they treat the autoantibody positive and autoantibody positive patient, and then they respond, they failed this trial, and they reported a major side effect of therapy, such as hypertension, diabetes, in 15% of patients who's going through this treatment. Interesting of this treatment plan is they give the prednisone throughout the pregnancy. It was relatively high dose, maximum 60, and some cases 40. So it was a relatively high dose of prednisone throughout the pregnancy. And this is the outcome. They don't see that much difference in the success rate. But then when you see the delivered baby, prematurity was severely increased in treatment group. And after this data, prednisone was regarded as a real dangerous medication. But you really need to see the actual data, what they're talking about. This is high dose, and they continue throughout the pregnancy. So in 2 years later, then there's another trial using the prednisone and low-dose aspirin versus low-dose aspirin alone. And that was the treatment for 3 or more unexplained recurrent pregnancy losses. they select a patient with autoantibody negative and also autoantibody positive. The difference in this trial is they used a low dose, 20 milligram per day and up to 12 weeks, just limit to the first trimester only. So there's a huge difference between the first one. You can see the success rate was significantly different between the aspirin alone and prednisone and aspirin. That was different. And antibody positive group, they were only treated with the prednisone aspirin. That was still different in here. So they reported that the prednisone and aspirin seem to be as efficient in autoantibody negative or autoantibody positive women when you use the low dose during the first trimester. So then in 2006, there's another trial comes, which is a combination treatment of prednisone, aspirin, and they include the folic acid and progesterone. In this study, they included women with a history of recurrent pregnancy loss of unknown etiology, and they restrict the patient who has 3 or more pregnancy losses. And here, again, they used the prednisone 20 milligram up to the 12 weeks of gestation because the previous trial was good. And they reported the live birth rate was significantly higher in treatment group versus control. So you can see the huge difference in here. And then they compared to the other parameters with the controls, gestation age at delivery, birth weight, and the first, second trimester abortion or prematurity rates were about the same. So we learned, yes, seems like a working. And then in 2008, they compared the heparin and combined the prednisone treatments. It's a very similar protocol. We just review it. Then they compared with the enoxaparin treatment group. And they used 3 or more idiopathic recurrent aborters. So in that trial, they used prednisone 20 up to 12 weeks, and then add up the aspirin up to 32 weeks. So this is another one arm, and enoxaparin 20 milligram was given. There was another arm, and they compare the outcome compared to the placebo. These two groups does very similarly. So that's what we learned from here. And outcome, when you see in here, success rate was reported as about 80 to 85% ranges. Actually, combination group does a little bit better, but there's no difference between these two. And live birth rate was about 89, 85. So, very good success rate compared to the normal controls. So in this study, they report heparin as similar to the combination treatment. And in 2000, Dr. Giva also reported in the same similar protocol works in the IVF cycle. The other trials are for the recurrent aborters. This trial is for the IVF failure population, and they found if they treat with a similar protocol, the success rate was about 32.7% pregnancy rate versus 12.5% pregnancy rate in who did not receive this combination treatment. And they treated a little bit less than the previous trial. They treated the prednisone of 10 milligram a day. So another half they used, and then combined with the aspirin starting the 4 weeks before the induction of ovulation. So they started about a month before, but they used a half dose of prednisone, and they see the success rate is increased. So from these trials, we learn high dose, longer duration of prednisone treatment significantly increases the medication-related side effect, and outcome was very poor. And high dose, longer duration prednisone and low dose aspirin treatment is not effective in women with 2 or more idiopathic recurrent pregnancy loss. However, the low-dose prednisone treatment during the first trimester does not really increase the side effect, and prednisone low-dose aspirin combination treatment seems to be as efficient as in autoantibody negative or positive women. So they just expanded the population, and they are doing better than low-dose aspirin treatment alone in autoantibody negative women. And low-dose prednisone, low-dose aspirin and progesterone treatment is effective treatment, and success rate was very similar to enoxaparin trial in women with 3 or more idiopathic recurrent aborters. So we're learning more. It took a long time, but we're getting out of some information regarding the prednisone and aspirin treatment. And another approach is getting popular is IVIG treatment. It's a high-dose immunoglobulin G, and IVIG does many immunomodulatory effects, and T-cell receptor blockade, inhibition of NK cell activity, and inhibition of T helper 1 cytokine secretion, and so on. So it does quite a bit of immune regulatory mechanism. And when you see the NK cell cytotoxicity, you can see there's a dose-related suppression of NK cell activity in vitro. So this is one of our students did. And the suppression is mainly through the Fab2 portion. And this is with IVIG. This is only Fab2, and this is control. So we learned the suppression of NK activity through the Fab2 proportion. So there is one trial done in 1996, and we used the IVIG heparin and low-dose aspirin versus heparin and low-dose aspirin. And we divide the group based on their NK cell level. If their NK cells are elevated, then we use the IVIG in addition to the heparin and the baby aspirin. So we use the heparin preconceptionally and use the IVIG preconceptionally. That means we give the IVIG even before they ovulate and then continue. And then we found in women with a normal NK without the IVIG, they do quite good. Women with the elevated NK, if they add up the IVIG, their success rate is much higher than women without the IVIG treatments. So if they have some evidence of cellular immunity activation, seems like IVIG is working well. And indeed, when we look at the pre-IVIG and post-IVIG data, NK cell level, especially CD56 and 16 levels, are significantly downregulated about a week after the IVIG treatment. This is from the different group. Dr. Perricone also reported NK cell cytotoxicity before IVIG was decreased after the IVIG treatment. And then T helper 1 and T helper 2 response was also reported to significantly decrease after the IVIG. The P level was 0.01, and this was reported in Dr. Grapo Ditula's group in Greece, and they reported the T helper 1 and T helper 2 response was significantly decreased in these two groups. One group involves APA, the other is not, but in both groups, they see the significant shifting of T helper 1 immunity to T helper 2. And this is the IVIG treatment in SLE group, and they started to check up these autoantibodies at the end of pregnancy. They repeat the testing after the multi-dose of IVIG treatment. You can see the antibodies titers are quite reduced compared to this prevalence. So IVIG is a good medication to control this autoimmune issue. And in SLE patients, they have 100% success rate in this small trial. So I don't know what 100% means in out of 12 patients. But then somebody who didn't get the IVIG and treated with a prednisone, they have a 75%. Well, we're having an IVIG trial. What we learned is the obstetrical complication. So this is the first data we reported when we were doing the LIT, or paternal lymphocyte immunotherapy, and then the anticoagulation treatment together. Significant portion of patients delivered before 36 weeks of gestation. So this line is 36 weeks. And about two-thirds of close to two-thirds of the babies were born before the 32 or 36 week. and then significant portion of the babies are less than 10 percentile. So babies who are born, but they're smaller, they're premature. And this is the IVIG data. And we have a series of IVIG patients. We don't have any small for gestational age babies. Still, we have some proportion of women deliver prematurely, but then the small babies are gone. So IVIG does something better than the prednisone LIT or the heparin trial. So there is one trial, they use the IVIG and then the prednisone and low-dose aspirin in a patient who has antiphospholipid antibody and who has a 2 or more recurrent pregnancy loss. They don't see any difference in live birth rate, 78 versus 76. However, they see the mean birth weight was higher in IVIG group than the prednisone plus LAD group. So it's very similar to ours. And then prednisone plus LAD versus IVIG. Prednisone group has higher incidence of hypertension, PIH was higher, and gestational diabetes was almost 3 times higher than the IVIG group. So regarding the obstetrical complication related to the steroid, IVIG does not have that. And this is the meta-analysis done for the first time in 1998. They reported the odds ratio of IVIG was 1.48 and absolute treatment effect was 10.1%. When they look at more carefully, you see the IVIG effect more in secondary recurrent abortion, not the primary, and odds ratio was 2.71. And then this is the analysis of IVIG coming out in 2010. And this is not the meta-analysis. This is her trial in most recent one. And she reported idiopathic secondary recurrent abortion cases. There's no benefit from the IVIG. And in this case, she really kind of randomized the population, but what she was looking for is these patients are not autoimmune. This patient has no marker. This patient, we don't know why they are miscarrying. So this is basically empirical use of IVIG, and you don't see any benefit. And when you add up Mary Stevenson's 2010 data, still the IVIG is effective. So odds ratio is 2.1, which is still significant. So even adding up that negative study, IVIG seems to be quite effective. So when we look at this IVIG meta-analysis, this is the actual analysis, and the reanalysis was done to divide the group with a patient who has immune positive data. When they treat the IVIG and they don't treat it, you see the difference between these two and difference from here to here. So IVIG is really working well in patients with the immune test positive, but not as an empirical treatment. And IVIG was also utilized for the women with the multiple IVF failures of a known etiology, and using the live birth rate per embryo transfer and adding the data from the 2-cohort control trial, the meta-analysis shows the p-value of 0.0001. And number need to be treated was 3.7 women. So this is another population probably we have to look at more carefully regarding the IVIG. They may get some benefit out of this IVIG treatment. And as a result, the properties and scheduling of IVIG seems to be one of the major part related to the success rate, and different IVIG preparation vary significantly in their ability to suppress the NK cell activity, and selection of the patient with abnormal immune test is very, very important. Not giving them without knowing what they have. So there are problems with empirical use of this treatment. There must be a credible mechanism that the proposed treatment can correct. So one must show that in those who benefited, treatment actually corrected the problem. Not empirically, you just give and see the outcome. And there may be a real difference in randomized controlled trial outcome owing to the type of patient included and then the way the treatments was carried out. And in here, when you see all this randomized trial, a majority of trial is actually trying to looking at unexplained. So we really don't have any target to treat. We don't know what we are treating. So I think finding out the credible mechanism is very important. With a meta-analysis, it's very clear. If you find that the patient who has immunological abnormalities, those are the one who has a better outcome. So there are multiple, treatments are out there. I just try to summarize it. The patient with some NK cell pathology or shifted T helper 1 immune response, autoimmune abnormalities, and then autoimmune abnormalities related to the rheumatic markers or the thyroid disease. And there are some report about the steroid treatment or the IVIG, and that there are some coming regarding the intralipid and anti-TNF. These are not complete studies. We don't know exactly what's going on. However, these steroid and IVIG data are more compiled than this. This is pretty new. It's only from the one team, and this is another team. So this is very, very premature. And the thyroid supplementation meta-analysis out. So these are relatively strong data out there. So when we evaluate the patient, we really need to look at all this probability and then select the patient, then probably the outcome will be better. So further clinical studies are needed to confirm the effectiveness of various treatment I mentioned. And future trials should be based on the credible mechanism, not empiric, randomized controlled trial. And effective women should be counseled now, although the immunomodulation treatment may result in an increased likelihood of success pregnancy. The limitation of currently available data should be discussed with the patient. And then a decision should be made that takes patient and physician's preference into account. And new investigational drug trials should be performed as a clinical trial at academic centers until the credible data is available. Thank you for attention.